Hi, I'm Matthew Weinstock, Senior Editor at Hospitals and Health Networks, reporting to you from Phoenix, Arizona, site of the 25th Annual Rural Healthcare Leadership Conference. Like everyone else in healthcare, rural hospital executives are trying to navigate their organizations through some uncharted waters. Perhaps that's one of the reasons why we've got record-breaking attendance at this year's meeting. More than 567 rural hospital executives and board members are here to talk about the transition that healthcare is undergoing. I talked with John Supplitt, who heads the American Hospital Association's Small and Rural Hospital section, a little bit about the challenges facing rural hospitals today. So John, thanks for joining me today. Tell me, what are some of the hot issues that are facing rural hospital executives these days?
Well, Matt, thanks for having me. And I would say that the biggest issues that are facing rural hospitals these days are payment and workforce. And regarding payment, first there's the threat of cuts to hospitals as a result of H.R. 3630. And in this bill, the House is proposing to reduce Medicare payments for bad debt for services provided to low-income Medicare beneficiaries. They're also proposing reduction of payment to services for evaluation and management for outpatient services. And then they're extending the exceptions process for therapy caps that pertain to outpatient services and skilled nursing facility, as well as authorizing CMS to make additional retrospective cuts to Medicare for coding adjustments. In addition, you've got the Medicare payment adjustments as part of the extenders that are going to sunset this calendar year, including reductions for outpatient hold harmless payments to rural hospitals, cost-based payments to small rural hospitals, super rural hospitals for clinical lab referral services. You've got the sunset of the low volume adjustment, as well as the conclusion of the Medicare dependent hospital provisions, all of which are of extreme importance to rural hospitals.
So it sounds like there's a lot, at least on the congressional front, that's impacting rural hospitals on that reimbursement issue. We've got more than 560, almost 600 people here at Phoenix for this Rural Leadership Conference, a record-breaking attendance. Obviously, some of these issues will be on their plate as they go through the week here. But what do you think some of the major themes we're going to hear over the next couple of days will be from the executives and board trustees who are here?
I know one session is dedicated to community recruitment of clinical professionals, which really does address the workforce issue, which is a huge issue for rural hospitals. The recruitment and retention of primary care physicians is always been a priority because of the maldistribution of those clinical professionals across the country. So in order to assure that there's some sort of consistency in the access to quality healthcare services, that's a good session that's out there as well. I think also when you look at the agenda that Laura's put together, or my colleague with the Healthcare Forum, she's got some excellent programs on patient safety and quality, some great programs on the medical home and patient-centered care. I think also when you look at what they're doing in terms of management and ownership options are also great sessions. And then I'm personally looking forward to the plenary sessions, the federal update by my colleagues from AHA, Lisa Kidder and Joanna Kim, as well as the plenary session on healthcare reform for rural hospitals that's going to be presented by my esteemed colleagues, Dr. Clint McKinney and Dr. Keith Mueller from the University of Iowa and the Rural Policy Research Center. I think those sessions will be very good. All the information is particularly relevant, and probably, other than the policy stuff, it's going to be of immediate use to rural hospital CEOs and leaders when they go back to their communities.
And one of the other themes we're going to hear all week is the impact of health reform on rural providers. It's something I talked to Keith Mueller about. Mueller runs the Rural Research Policy Institute at the University of Iowa, and he appeared on a panel with experts who talked about the Affordable Care Act and its impact on rural providers. So Keith, thanks for joining me today. I know one of the things you're going to be talking about on your panel discussion is the transition to value-based healthcare system, accountable care, medical homes. Tell me, what are some of the things that rural hospital executives should be doing now to build what I think you're going to talk about, this high-performance, sustainable healthcare delivery system?
Well, one of the things they need to be doing, that they are in many states around the country, is developing different measurement systems in their hospitals. So the Medicare hospital compare site has reporting mechanisms. There's a special program out from the Federal Office of Health Policy on quality improvement measurement in the critical access hospitals, the smallest of the nation's hospitals. So that's one aspect, is to keep moving down that pathway of measuring the process of care and the outcomes of care that result from a patient coming to the hospital. A second is to really tighten up, if they aren't already, relationships with the clinical community, particularly the physicians that practice at the hospital. A lot of what will be done over the next 15 years in terms of providing and improving value will really be physician-centric, not hospital-centric. The third and final opening comment I'd make is the hospitals need to be thinking about even broader networks. The notion of value for the patient means my total health care. It doesn't mean just the services that I acquire locally, like primary care, some general surgery. It's the whole continuum of care. And some of our payment systems, public and private, are moving in that direction. So to do that, a hospital exec, if not already part of networks of some kind, will need to think about that. You know, how do I participate in a regional network? I don't necessarily have to sell my hospital. The community doesn't have to sell the hospital to do that. It can be an affiliation. It could be multiple affiliations. But that, again, represents a different mindset than the independent hospital that has dominated over the last 40 years.
So those are some of the organizational and strategic things that they could be thinking about moving forward. What are you finding at the Policy Institute that are some of the policy limitations to creating these high sustainable, high reliability, high performance organizations? And what do we need to be looking at from a policy front?
Payment policy needs to be changed, is being changed at the federal level with the value-based purchasing programs for inpatient hospital, for skilled nursing, a value-added modifier in physician payment, a demonstration program at some point for critical access hospitals. It's supposed to happen starting next month, but we'll see. The pace of change in that last point I just made about CH demo starting in March by statute, but probably will be delayed, is really an issue of the public-driven change is lagging. You know, I think some major private carriers, some major Blue Cross plans, Aetna, Cigna, are already farther along on changing the way they pay for care, on working with the accountable care organizations. They're farther along in that than is the federal payment system. So one of the challenges we have is the federal system trying to catch up to some of the innovations that are underway on the private side.
Well, great, Keith. I appreciate you taking the time to join us today. And I'm Matthew Weinstock, reporting from the 25th Annual Rural Health Leadership Conference in Phoenix, Arizona. We'll have more coverage of the meeting in the next couple days on H&HN Daily. Thanks.